Hello! Welcome to the wonderful world of urology, full of cool cases, crazy kidney stones, and interesting bladder tumors. The first thing you need to know is the physician that performs procedures within the genitourinary specialty is called a urologist. Urologists are responsible for the anatomical structures in men and women that include the kidneys, ureters, bladder, and urethra. Urologists also care for the male external anatomy and reproductive system, which includes the penis, testes, scrotum, prostate, and accessory structures. Urology procedures are classified as either open or closed. If an open procedure is to be performed, that means an incision is required. That incision may be a large, open incision, or it could be smaller, MIS incisions, which may entail laparoscopic or robotic techniques. A closed procedure indicates that the procedure will be performed transurethral endoscopically. Much like the GYN specialty, there is a natural orifice involved in the anatomy within this specialty. You'll recall from GYN that when our patients experience troublesome symptoms, they usually require operative endoscopy without incisions. The surgical technologist often must have a rigid scope to accomplish this because it can accommodate tissue resection better than a flexible scope can. This is still considered closed surgery. As we progress further into these surgical procedures, you can start to rely on knowing whether you're about to do a flexible endoscopy or an endoscopy with a rigid scope based on the specific structure involved. Using my personal experience as a reference, I have learned that the further the distance the scope needs to travel after entering a natural orifice, the more likely the surgeon is to use a flexible scope, versus the shorter distances are usually accessed with a rigid scope. Furthermore, the bladder don't get scoped for preventative reasons like the colon does. They get scoped because the patient is experiencing symptoms warranting a peek inside. We will need to be prepared to do an operative procedure, like excise a bladder tumor, and the rigid scopes are more accommodating than flexible ones. Remember, endoscopy involves both MIS and flexible endoscopy. Use of a rigid scope through a natural orifice doesn't really fall into either category nicely, and I'm aware of that, but it's just a part of surgery life and we have to accept that. You can obviously ask me questions about this, but trust me when I say it'll make a whole lot of sense when you see it at your clinical sites. Before we move on, there are some surgical procedures listed on this slide, and we'll go over them during Jigsaw, but they are listed accurately here to give you an idea of what types go into which categories. It's important for you to know where the kidneys are located, and that is in the retroperitoneal cavity. Remember, our peritoneum envelops our entire abdominal cavity, so there's a ventral portion and a dorsal portion, so to speak. When we go through the dorsal portion of the peritoneum, we call that the retroperitoneum. They sit at about the 12th thoracic vertebra, and the right kidney sits a little lower than the left. The kidneys are embedded in dense tissue, which helps protect and support them in that retroperitoneal space. The kidneys are the main filtration system of our blood. They filter our blood through nephrons, which communicate via a network of capillaries and tubules within each kidney. These capillaries in the kidney have a specific name, and that is glomerulus. Repeat after me. A nephron communicates with a glomerulus and filters our blood. Each kidney has about 1 million nephrons and glomeruli. It is this filtration system that can be a major concern for nephrologists because if the kidneys don't filter the blood properly, their blood will essentially become toxic and they'll need to be put on dialysis in order to facilitate blood filtering while bypassing the kidneys. You will learn about a particular procedure in this unit that is actually performed by a vascular surgeon, but it is done because the patient's kidneys aren't filtering the blood properly and they need hemodialysis. This slide shows you a drawing of a kidney as well as a cadaver kidney. Each kidney weighs about 1/3 of a pound. which is roughly 150 grams, and they're about 4 to 4.5 inches long. They have two layers, the cortex and the medulla. The cortex is the outer layer, and the medulla is the inner layer. The medical terminology you need to know is renal and nephro. Nephro is the prefix used to indicate kidneys, like nephrectomy. And renal is the medical descriptive term used for things pertaining to kidneys, like renal arteries. And we know that arteries carry oxygenated blood, so the renal arteries are the ones that provide oxygenated blood to the kidneys specifically. The kidneys connect and drain into the urinary bladder via the ureters, which are approximately 12 inches long. The waste produced by blood filtration in the kidneys is called filtrate. This substance flows from the kidneys through the ureters into the bladder. Once it enters the bladder, it's called urine. The ureters are obviously an important anatomical structure for this purpose, but they are also a critical landmark in pelvic procedures because they are intimately involved with other vessels and organs. Therefore, accidental ureteral injury is a dreaded consequence of pelvic surgery. Filtrate is moved through the ureters by peristalsis. Just like the intestines, the contents move through the structure due to periodic contraction and relaxation of the involuntary muscle tissues. Peristalsis resembles wave-like motions. The ureters connect to the bladder and the ureteral orifices. Because we have a right and left kidney, we have a right and left ureter, and therefore a right and left ureteral orifice. In this zoomed-in image, the right and left ureteral orifices form the two corners of the bladder trigone, and the third corner is the urethral orifice. Be careful not to confuse the ureters with the urethra like I just tried to do. The urinary bladder is controlled by the autonomic nervous system. The ANS controls when the bladder is emptied. The bladder is composed of 4 tissue layers. From innermost layer to outermost layer, they are the inner mucosa, followed by the submucosa, then the muscular layer, and then the outer serosa. Just like the intestines, the mucosa is on the inside and the serosa is on the outside. When we're participating in procedures of the bladder, the urologist typically sutures the mucosal layer and the serosal layer specifically, much like intestinal surgery with our general surgeons. Remember, we're not working on a microscopic level in surgery, so some layers are combined with one another during closure. The urethra is the passageway for urine to exit the bladder and subsequently the body. As you can see on this slide, the urethra is a different length in females compared to males. Regardless of sex, however, the urethra originates at the trigone and ends at the meatus. Male urethras have 3 distinct sections. They are the prostatic, membranous, and cavernous urethras. I tell you this because the prostatic portion of the urethra is surrounded by the prostate. So when a patient is scheduled for an open prostatectomy, part of their urethra will be resected, and a necessary step in the surgical procedure will be the reanastomosis of the urethra.